Hi, I'll brief you about the instruments used for tonsillectomy. This video is mainly meant for undergraduate students and those postgraduate students who have taken ENT as a specialty. I am Dr. Zakir Hussain, Senior ENT Consultant. Now, before going into the topic, let me tell you in brief about the evolution of the procedure, tonsillectomy. Way back, almost about 4,000 years back, in Indian scriptures, it has been documented that the mass behind the tongue has been removed by technique called scraping. So the mass behind the tongue, it has to be tonsils only. So this I am saying about 4,000 years back. As time went on, during the Roman period, Dr. Celsus, he understood the importance of tonsillitis and he performed tonsillectomy just with bare fingers. He removed the tonsils from the base of the tonsil, from the tonsillar fossa. And it was noticed that after the surgery, all the children, they improved. This is during the Roman period. As time went on, during the Greek period, they developed tonsillar snare. Please keep in mind that all these procedure being done without anesthesia and there is no proper medicines those days for control of bleed too. Now, after that, because of these complications, there was a technique called strangulation which was practiced by few doctors, where they'll tie up a thread around the tonsil and every day they used to tighten it up and knot it. And as and when the days went on, the tonsil used to fall off, but it did not gain much of importance. Then, during the 18th century, the tonsil guillotine was introduced. The main problem with that was severe bleed. And later on, Dr. Ballinger from America, he introduced scalpels and forceps for removal of tonsils. That is about evolution of tonsils. Now, you have so many different techniques of doing the tonsil. The one in this video, I am going to demonstrate mainly the traditional technique where we use all the different types of instruments. I have been teaching in government hospital for a very long time abroad, and I tell my students that always when you do any procedure, surgical procedure, you start with the basic technique and use the basic instrument and not use the latest one. So in this video, I'll show you about the basic instruments. Okay. All the tonsillectomy, adenodectomy, all the procedures are done under general anesthesia. Gone are the days where it was done under local anesthesia. Right in front of you, you have the full tonsillectomy set. So, I will tell you in brief about each instrument, okay? Now, first about the Boyle-Davis mouth gag. There is a Davis mouth gag. This is U-shaped frame. This is the tongue blade which has to be attached to that. This is a Boyle's tongue blade with a groove and there is a guard in the end also. There is a ratchet and next instrument is the tonsil holding forceps. If you see the tonsil holding forceps, the upper one is smaller and the lower one is larger. This is Dennis Brown tonsil holding forceps, or you can have Negos or Valsalem tonsil holding forceps also. This one, if you notice, in the ring, in one of the rings, there's a small opening. There's a small opening. We don't use this very often. Usually the Dennis Brown tonsil holding forceps are made use. Sometimes what happens is the tonsil used to be very fragile. So when you hold the tonsil, it comes off in pieces. So that particular moment, if that type of tonsils, we use this instrument because the end of this instrument is sharp and curved and serrated also, so that it catches the tonsils properly. Not only that, there's a tenaculum, there's an opening in the ring. When you engage the tonsil with this, once it is engaged, then we will not let it go. Once the dissection of the tonsils from the upper pole to the lower pole is complete, we'll use the Eve's tonsillar snare, which is kept here. I'll demonstrate, which has got a wire, and without disengaging the tonsil holding forceps from the tonsil, we'll introduce the wire through the opening here. That's the Eve's tonsillar snare. I'll open the wire, and through one of the opening, we'll slowly engage it from one side. It's there only on one side, and I'll bring it to the end so that we don't have to remove it. I'll demonstrate now. Just have a look. See, it comes to the end. Then we can snare it off. There's a tenaculum. The different parts are the serrated ends. There's a joint there. There's a shank. These are the rings. One of the ring, it has got an opening. These are the different parts of the tonsil holding forceps. Coming to Eve's tonsillar snare, it has got 3 rings. The thumb will be here on the last one, and the ring finger and the middle finger, the other 2 one. There's a wire. It's a piano wire, 3-inch long, 28 gauge, to engage the tonsil in the lower pole and crush it. This is Mollison's anterior pillar retractor. I'll demonstrate each instrument during the surgery. This is Wine's tonsillar dissector. This is McGuerin plate. This McGuerin plate, this is a foundation. There are so many slots in that, equal on both sides. Spots or slots. It will be kept behind the neck so that we can anchor the Draffin's bipod stand. I'll show you that. That is McGuerin's plate. This is Draffin's bipod stand. So the lower end, we'll engage it in one of the slots, and we'll choose the lowermost part to start with. We'll see how it gets engaged. Okay. This is Burkett's long, slender hemostatic forceps. If there is a bleeding, catch the spot, then replace that hemostatic forceps with the Negus curved forceps. Remove the first one and tie up the bleeding point. Now about the surgery. The assistant is keeping the shoulder back, followed by head ring, and one person is holding the endotracheal tube. I am advising them, I am asking them to lower the head end of the patient so that the patient does not aspirate. The head should not be hanging free. Now, once the patient is positioned, what we do is we'll start with the Boyle Davis mouth gag. I am holding the tongue depressor here. So this tongue depressor, you have pediatric tongue depressors and adult tongue depressor. Numbering starts from 1 to 5. So how to decide which tongue depressor to use? The simple way is take one of the tongue depressor and place it on the side of the face. and this end at the tragus of the ear, and the other end should correspond to the angle of the mouth. The distance between the tragus to the angle of the mouth should be same as the length of this blade. That's how you choose the size of the blade. And once it is engaged, you make sure that the base of the tongue is well retracted and this guard in the end does not touch the posterior pharyngeal wall, does not injure the posterior pharyngeal wall. Now, this tongue depressor will be put in this slot. So, with this finger, I'll press the ratchet. You can see here, I'm pressing it here and slowly introduce. See, I'm pressing there and slowly introduce it and position it, and always have a guard to protect the incisors. McGuire's plate is already placed. I'm using the lower, out of the 4 rings, I'm using the lowermost ring and positioning it equally on both sides, starting from the lateralmost position, and to see that the tonsil's lower pole is well exposed and the pharyngeal wall is not injured. I'll put a catheter through the nose and bring it out to the mouth, slowly retract. Either you can tie it off and or hold it in position with a forceps. When you operate the right tonsil, use your right hand, and when you operate the left tonsil, use your left hand. Please do not cross your hands while operating. This is a throat pack which has to be kept first and the last to be removed. So right tonsil to be removed first. I am taking the tonsil holding forceps and hold the one sister is holding the Youngers suction, just to retract, not to suction. So tonsil holding forceps, or you can have the other forceps also, Valsalem or Negus forceps also, and hold the upper pole of the tonsil. Do not hold the tonsillar pillars, only the upper pole. Once the upper pole is well caught, once you hold it properly with the Voss forceps, slowly with upper pole, slowly dissect I'm holding the upper pole, and with the Voss forceps I am removing the tonsil upper pole, making it free from the anterior pillar and the posterior pillar. Once that is done, you replace the instrument with Wine's tonsillar dissector. This is the Voss tonsillar forceps. This is Wine's tonsillar dissector. Now you dissect, free the tonsil from the anterior pillar, posterior pillar and the upper pole, and from the upper pole to the lower pole slowly. As you can see, there is not much of bleed. Proceed slowly, and it has to be in the plane. It will be white shining plane. When you are in the plane, it will not bleed much. Once you are in the lower pole, I am making use of the tonsillar snare. Slowly hold the forceps, introduce the tonsillar snare, and just engage it and cut off the tonsil. Once the right side tonsil is removed, keep a forceps for a few minutes, and that's that Mollison tonsillar retractor. Just to demonstrate, I am using a bipolar, that's all. Now I have started doing the removal of the left tonsil. So as I have mentioned, when you use the left tonsil, use your left hand. Use your left hand. Do not cross your hands. Okay. That's how it is done. Now all the packs will be removed one by one. check for any bleeding or not. Throat pack is the last to be removed. Draffin's bipod stand is removed. Disengage the Boyle-Davis mouth gag. Flex the neck, leave for a few minutes. Reopen it to see whether it is bleeding or not. Reconfirm that it is not bleeding. It's clear. Then with an instrument, hold the endotracheal tube properly and remove the mouth gag. Do not let go the endotracheal tube. Check for the teeth, any dislodgement, any movement. Check for the lips, any injury or not, and the TM joint also. So, I am the author of this book, Instruments in Otorhinolaryngology, Laryngology, and by the way, this is the 4th edition. In this book, I have detailed about whatever I have shown you in this. The specialty, the difference, the specialty of this book is that each instrument, I have given a short history about the instrument. Not only that, the indications, the way to use it, and the different parts of the instrument. For example, if you see this picture, Boyle-Davis mouth gag, this is Davis mouth gag, and this is Boyle's tongue blade. The tongue blade has got a small curve in the end, and this is a lever. This is a ratchet or the adjustable lever, and this is a central groove, if you can see here, which engages the endotracheal tube, and at the end there is a guard, and this is a U-shaped frame. This is one of the instruments. The second instrument is the Eaves tonsillar snare, which has got 3 rings. It has got an outer cannula or inner cannula, outer hollow cannula, inner wire carrier, and the wire which is used here is a piano wire 28 gauge, which is about 3 inches long. So I have given the name and different parts of the instruments also. And this is Younger's suction, which is used by the general surgeons also. It has got 2 bends so that the curve helps the surgeon to visualize the field better. And the tip of the Younger suction, around the tip you have multiple small holes. In the center also there is one, and the cap is blunt so that it does not injure the operating field. Here I have demonstrated only 3 instruments. In the book, almost some 13 to 14 instruments are given. Just to give you an idea how it has been written. Now, to summarize, here you have Boyle-Davis mouth gag, McGuerin plate can be seen, Draffin's bipod stand, tonsil holding forceps, then you have Voss forceps, Wine's tonsillar dissector, dissecting from the upper pole has already been dissected. Now here we have reached the lower pole and the Eaves tonsillar snare is engaged. Once that is tonsil is removed, with Mollison's anterior pillar retractor, I am retracting the anterior pillar to examine if there is any bleed or not. This is Burkett's straight, slender hemostatic forceps. So we have, if there is a bleed, we have to catch the bleeding point, then replace it with a Negus curved forceps and apply the tie. The tie will be negotiated into the tonsillar fossa to the bleeding point with the help of Negus knot tie and suture the bleeding point. So all the details, the different indications for the surgery, what are the contraindications, this is mainly meant for, it will help you for in the operation theatre, and it will help you for to face the practical exams also. Thank you so much.